Hello, I am Prem Ranjan. I am the Product Manager of Electric Acoustic Systems working at the MEDAL headquarters in Innsbruck. I would like to welcome you today to another Hear Better video. Thank you, enjoy. Today I am going to talk about the electric acoustic stimulation, which is an optimal solution for users with partial deafness. The research started way back in 1997 when the partial deafness was researched with the introduction of a cochlear implant electrode, and over a period of time MEDAL has continuously invested and made incremental improvements not only in the electrode design but also in the external processors and the EAS indication. As you can see that in 2007 we already received the TÜV approval for EAS indication, and in 2011 the EAS was approved for all age groups. In 2016 we received the FDA approval for EAS in adults, and 2017 brought an important landmark when the measurement of cochlear microphonics from the cochlea was also CE marked with the MEDAL system. In 2019 we were already celebrating 20 years of EAS. It all started with this typical patient group who presented with bilateral severe to profound sensorineural hearing loss, as you can see in the red shaded area, and these patients were implanted with a longer electrode which could cover the entire cochlear duct length, basically achieving a complete cochlear coverage. At the same time, there was another group of patients who had good amount of residual hearing in the low to mid frequencies, and the hearing loss progressed to severe to profound range in the mid to high frequencies, as you can see in the red shaded area. And these patients here, the clinicians felt that a shorter cochlear implant electrode may be used so that the cochlear implant electrode is not entering in the residual hearing area of the cochlea. So here what was important was that the patients presented with residual hearing and an implant electrode was to be inserted in this cochlea, and therefore the topic of hearing and structure preservation was very, very important, because we did not want the patient to lose the residual acoustic hearing. In this study you can see that a 12 months long-term data was presented with the introduction of MEDAL's flex electrode up to shallow insertion in the cochlea, and in the 1 year timeline that you can see that the hearing thresholds changed by about 40 dB or less in different low to mid frequencies. Since the inception of MEDAL's flex electrodes, various researchers around the world also started to think what happens when the low frequency threshold of the patient changes or it becomes worse, and if there is no cochlear implant electrode in the most apical areas of cochlea, then how these patients may cope up with a shallower inserted electrode. And their research was directed in the direction of introducing a full length electrode to give complete cochlear coverage in patients, both children and adults, with the typical EAS indication. As you can see in the slide, that 6 months post-op data is presented, and residual hearing was preserved in the first 6 months after cochlear implant electrode insertion. Since the inception of the flex electrodes in 2010, where the flex electrodes were specially designed to be further atraumatic to preserve the structures and hearing of the cochlea, various researchers around the world also started to look at the importance of achieving a complete cochlear coverage right at the beginning in the patients who had typical EAS indication range, not only adults but also children. And the data what you see on the slide shows 6 months hearing preservation data after the initial surgery, and you see again that some or the other degree of hearing was preserved in the low to mid frequencies. And in this slide you can see again a collection of literature where various surgeons, various researchers from around the world reported their hearing preservation data with different MEDAL's flex electrodes, and you can see the hearing preservation was reported between 80 to even 100%. And while we are talking about the topic of hearing and structure preservation, the way this is very important for our patients because they have some amount of residual hearing which they would not want to lose. There's also a novel tool which is called the electrocochleography measurement, by the help of which we can measure the cochlear microphonics from inside the cochlea, and this is a new tool which is helping various surgeons around the world in understanding how the cochlear microphonic potentials are changing during the electrode insertion and also after the surgery. With this tool, we can measure the cochlear microphonics of the patients even when the hearing threshold of the patient is 100 dB HL. In this study, what you can see on the slide, the author tested the patients with acoustic stimulation at 500 Hz tone burst, and the hearing levels of the patient varied between 10 to 100 dB, and the recording of cochlear microphonics was systematically obtained in these patients, and the authors concluded that it's possible to record the cochlear microphonics in patients with very low level of residual hearing. And in another study, what you see in this slide, that the authors conclude that this novel approach using electrode array to detect and measure intracochlear microphonics shows promise as an instrument to alert surgeon to hair cell damage during electrode insertion. So how do we do this measurement? As you can see in the picture on the slide, that while the patient is being induced, the insert ear receiver is already put in the ear canal of the patient, and the acoustic stimulation would be delivered by the help of an ABR device, and the measurement will take place via the max coil in the Maestro software. This measurement can not only be done in adults, but this measurement can also be done in children, not only during a unilateral surgery, but also during bilateral surgery. So for those of you, if you're wondering how this measurement looks like when we are doing it in the operating room, so here now on the slides you are going to see a real recording done on a patient who was an adult, and a Synchrony Flex 28 electrode was used on the right side, and an acoustic stimulation of 500 Hz tone burst was delivered to the patient. As you can see in this slide now, that in an average cochlear duct length, the 500 Hz tonotopic location would be roughly located in the red donut area, what you can see. So that is the sweet spot which I have just used as a visual representation. When the electrode insertion starts from the round window, we will start measuring the cochlear microphonics from channel number 1, which is the most apical channel in the metal electrode, and you saw that there is a flat line. When more channels are inserted, you still see a flat line, there is no response recorded so far. And when the electrode insertion advances further, and when the recording electrode number 1 moves closer to the sweet spot, you see that the amplitude of the cochlear microphonic also increases. So as you can see now on the slide, that after the end of the electrode insertion of a Flex 28 electrode, the cochlear microphonic amplitudes were still recorded. If you are wondering whether this measurement could only be done intraoperative, not only intraoperative, but this measurement could also be done postoperative. Now as you can see on the slide, that this setup is almost similar, that we are going to stimulate acoustically with the help of an ABR device, and we are going to record the cochlear microphonics via the implant electrode. On this slide, as you can see, that the cochlear microphonics were measured at different intensity levels, and when this was compared to the audiometric threshold of the patient at 500 Hz, the threshold of cochlear microphonic was very close to the patient's behaviorally measured audiometric threshold. In this study, the authors concluded that when the cochlear microphonics and the pure tone measurement, which is behaviorally done, when they are done at the same time, then they have a high correlation. And there is also good correlation of the cochlear microphonics and the pure tone measurement at 250 and 500 Hz. But the author also cautions that these two measurements are correlated when they are done at the same appointment. But if you're trying to correlate these two measurements when they are done at different appointments, then they may be affected by unknown change processes, so they wouldn't correlate that well. So now we have this patient who presented initially with some amount of residual hearing in the low to mid frequencies, and this patient was operated with a very nice, flexible, atraumatic lateral wall Medels flex electrode, and we were able to preserve the residual hearing of the patient after the surgery, And now is the time that we make the patient use the residual hearing to the best, to the most optimal situation. And how do we do that? Is by natural EAS fitting. How we do the natural EAS fitting is by first understanding the location of the implant electrode in comparison to the residual acoustic hearing region inside the cochlea of this patient. So we will first try to identify if this is a gap condition, whether the most apical electrode is a little bit away from the acoustic region of the patient, or whether this is a meet criteria, where the electrode is exactly at the boundary of the acoustic hearing of the patient, or this is an overlap criteria where a deeply inserted electrode is sitting in the natural acoustic region of the patient. Once we understand this, our Maestro software is very flexible and it gives us the flexibility to do a natural EAS fitting for this patient. And as you can see that the outcomes when we do this is very clear for the patient, that in this multicentric study, what you can see on the slide, the performances of the hearing aid use and post-operative EAS use were compared, and across the 5 different centers, on an average, a 50% improvement was seen with the use of EAS for the patients. Thank you so much for your attention and watching this video. If you have any further questions, or if you would like to know more, you can get in touch with me directly, or I would also strongly suggest you to sign up on our Hear Better network, and the address is hearbetter.medel.com. Thank you once again.